Welcome. Get my coffee. We're ready to go. Very grateful to Rob Reed from Databricks, not just for the coffee, but for giving us the opportunity to present today the work that Virtue Foundation is doing in partnership with Databricks, and to kind of showcase the work we've done to date and then the work that we've been doing subsequently with Databricks as a partner. So I'm Dr. Joan LaRovere. I'm co-founder and president of Virtue Foundation. I'm also a practicing clinician in pediatric cardiac intensive care at Boston Children's Hospital, where I'm the associate chief medical officer for transformation there. It's really an honor to be here today and present this work. Virtue Foundation's an NGO with special consultative status to the UN. We've been working in the global health arena for over 2 decades as an organization. And it was really all of the on-the-ground work, taking care of patients across Africa, Southeast Asia, Latin America, that led us to start thinking about the data problem in low and middle income countries. I'm going to start with a very quick video that kind of explains how our vision, the vision of my colleague, really, Dr. Ebi Elahi, who unfortunately can't be with us today. We've all just returned from Mongolia, and he had to go back to doing eye surgery in New York. But this will give you some intro to what we're trying to achieve.
Remains a significant challenge around the world, with half the planet's population lacking access to adequate medical care. Yet the technology and resources are there. The US alone donates more than $250 million and thousands of physician hours annually to short-term medical missions. But significant inefficiencies exist, causing unnecessary suffering. We believe this is a solvable problem, and that we can learn from models like the world's financial markets, which utilize big data real-time to facilitate the flow of capital. What if we could leverage technology to better match needs and resources and reduce the inefficiencies in the delivery of healthcare? What if we could use big data to make the invisible visible and see where the need is greatest, and then deploy those resources where they'll do the most good? We believe this is possible. The Virtue Foundation Data Mapping Initiative is a new tool that pulls data from myriad sources such as social media, detecting patterns through natural language processing, satellite mapping providing geospatial data on infrastructure, including roads and building heights, and then uses machine learning algorithms to deliver predictive analytics that match volunteers with the places, the projects, the patients that have the most need and can most benefit from their skills. Volunteers can use this technology to search for their specialty and indicate their preferences, and then learn where they will have the most impact. The result? Countless data points analyzed, thousands of doctors deployed, millions of lives impacted.
I hope that gives you some brief intro to what we're trying to achieve and have been building for now 15 years. It's this idea of improving efficiency in the flow of information as a way to save millions of lives. Each of us as clinicians, many embark on doing work in low and middle income countries. And knowing where to go, where the patients are, is a significant problem in terms of matching it to the specialty, since medicine is such a specialized service today. And it's really a lemon market. The market dynamics are broken. It's how do you make that invisible visible? And it's a real information asymmetry problem. The people who most need you have the least ability to make their needs known. We see it all the time traveling and working in low and middle income countries. It's often in the capital cities that it's sort of come here, pick me, choose me, or word of mouth. And it's wonderful because people are going and doing work and training up people on the ground. But it's not maximally efficient. And it's happened to us many times. You'll bring a team of eye surgeons or neurosurgeons or cardiac surgeons, and You really want to be able to treat the largest number of patients and link with the providers on the ground who can most benefit from the skill transfer. So we're trying to connect up the medical professionals that are available to do this sort of work with the nonprofit organizations and hospitals and healthcare facilities doing the work in the low and middle income countries on the ground. What we've subsequently found, as we've also worked with government partners, that they would like this granular information as well. It's a challenge because somebody who's trained in data science in a low and middle income country setting, they're generally not working in a government institution or in other areas of development. They're more apt to be in finance or corporate services. So this is also, I think, a great service at that level as well. There's currently 143 million people in low and middle income countries every year not getting surgery because they either don't have access or they don't have the necessary skill set on the ground. This is a large problem. And this is where big data, AI, machine learning can actually solve this and improve this, impacting not the thousands of lives that we impact as individuals in this medical care on the ground, but millions, because it can harness more people to go to the right places. We searched, as an NGO with special consultative status to the UN, we thought, well, this data must be within one of these large organizations. It's not in a centralized, easily accessible way. So that started us down this pathway of generating the largest data set of healthcare facilities and nonprofits, now across 72 low and low middle income countries. This is just a schematic of the original work that we did in creating that data set. And we've then published it with Taylor & Francis, which is one of the largest global health publishers, in the first World Compendium of Healthcare Facilities and Nonprofit Organizations. That was first in 2020 and the second more complete version in 2021. We coupled that with a digital platform so that you could access deeper layers of information. So for these hospitals, it's not just the name and location, but what are its capabilities? How many beds does it have? What type of specialties are there? Is there general surgery? What specialized surgery is there? Healthcare specific. We're trying to make this as specific as we possibly can. And then we created the first digital marketplace for global health philanthropy in VF Match in its beta version. I encourage you to come back and look at this later in 2024, when I think we're going to have a very robust, complete version of this platform. But you can see these healthcare facilities and their details. You can see the healthcare NGOs, which ones are working where, in what hospitals. We've networked this information. And then we have volunteer opportunities that NGOs place, and through that, we match them with the doctors and other healthcare professionals who wish to undertake this work on the ground. As I mentioned, we started by training a machine learning model to scrape the web real time and predict what is a nonprofit website. It was tens of thousands of validating hours on these first algorithms of many senior physicians, some of them chiefs of surgery in major hospitals around the world, helping us to make sure this was precise data. We did something similar for healthcare facility with custom filtering techniques to create that first unique data set across these 72 countries of their healthcare facilities. And our primary reason in doing that is that you need that foundational data set. You need to know where people can go for care, what are the capabilities within that care, and who else is an actor within that healthcare ecosystem to be able to start to think about how you can transform it and identify the medical deserts and target the right care to the right place to get to the right patient. So we've then taken that foundational data and layered it with other geospatially tagged data, whether that's nightlight data, population data, road networks, mammal movement, you name it, we've tried to apply it and try to identify key information that comes. Air pollution, solar. There are many things that help you identify what's really hidden in plain sight. And I'll talk a little bit later that once you have that, what's the purpose? It's this identifying and then impacting the shape of those medical deserts. Those areas where there are large populations of people who don't have access to care. And I'll give a couple of examples, one in terms of bringing care and the other in terms of access to care. But our goal is that this is a platform used not only by Virtue Foundation, but it's used by all NGOs and other healthcare actors to be able to be more precise and targeted in their initiatives. I'm going to kind of share the stage with Nicolas Douard, who is a data scientist with Virtue Foundation, and Van Dan Parma, data scientist from Databricks, to kind of talk through some of the work that we've been all doing together. And the first, we'll just talk a bit about identifying medical deserts.
Thank you. So to illustrate a couple examples about the kind of data we use and we require to predict and impact medical deserts, we're using today the example of Ghana. Of course, this methodology is meant to be generalizable across many countries. So here, as a first step, we're looking at the accessibility. So this is computed by integrating many data layers so that we can actually estimate the average travel time to different kinds of facilities. So this map shows like the darker parts are basically further away in terms of travel time to the facilities, and the lighter parts, of course, concentrated around cities and urban areas, are faster travel to get there. And we're breaking it down here. I mean, we're looking at any hospital, but we also have a breakdown in terms of medical specialties. So to approach this from different angles, different groups of hospitals, for example, hospitals that provide at least general or specialized surgery.
Yep. And these maps have been built across 72 countries by specialty and subspecialty.
And the second step here is plugging in the population data, population density. And I won't get into the details today, but from a practical standpoint, we estimate each hospital's catchment area or coverage area. And this map shows the overlapping coverage areas. So darker greens means that there is actually several facilities covering that area. And we run that against the population values to see which parts of the country fall outside of any coverage. And then for those parts that are outside of any coverage in terms of population, we plot the population density. So actually anything outside of red goes from a shade of lighter red to darker red. And so the areas that are more problematic are the darker red ones, for example, in the Northeast. And this is simply a different way to look at the same information. The middle one is representation in terms of political boundaries. So this could be more informative for government stakeholders, for example. And the right one uses the quad tree representation. So each cell contains roughly the same population. So that shows particular interest in the smaller cells that are colored in red, for example, in the Northeast.
So those are sort of traditional data science approaches. We then tried to look, once we'd identified these medical deserts, both by general care, general surgery, and then specialty and subspecialty surgery, to start to understand where should optimal locations be to build new hospitals, and where should we think about within already existing facilities, new levels of service should be developed. And that's when we started thinking about working on things more at an enterprise grade with enterprise partners. And DataRobot helped us with this phase of our work.
So here we're looking at an example over Ghana again on how we can predict which locations are best suited to develop new facilities. So we factor in different data layers such as elevation, population density, land cover, road networks, and other kinds of network, coupled with the locations of current healthcare facilities as a target. We employ a multimodal machine learning approach that combines image variables and geospatial location variables as well as numeric variables. to make these predictions. So this leads us to this map, which shows in green, you see basically the locations that don't currently have a hospital that could be predicted as suitable to develop a new facility. We have a suitability value, so darker green means more suitable. And in red, you have the locations of current hospitals. So this is a way to narrow it down. Of course, a big factor here, there is kind of two sides to this problem. There is like physical practicability. So, for example, not building a hospital on top of a mountain, not putting a hospital in the middle of a lake, putting a hospital near infrastructure, near roads. And then because population density is also used in this model, we're also going to try to bring hospitals close to where people live, which sounds like a reasonable thing to do.
And Nicolas presented this at the IEEE Congress in Copenhagen this year, and all of us were involved in publishing this methodology as well in IEEE.
And so the previous map is the first part of the equation. This is, very helpful, but you still need to narrow it down because resource is limited. Ideally, you would build hospitals everywhere, but you have to make a choice. So this second part of the methodology is about estimating impact in terms of if you were to build a hospital somewhere, what would be the reduction in average travel time for the people living there? And then what is the size of that population? And so from there, we can actually narrow it down to a short list of here, for example, 20 locations. That could also be 40 or 10, depending on the resources and what we're talking about. And also the interesting thing is that this is here, illustrated over hospitals, but we could also apply this methodology in terms of specialties and subspecialties, looking at other kinds of facilities, for example, specialized surgical centers.
I think the other profound thing that we saw, which was recursive across nations, is that the medical deserts actually turned out to be in the suburbs of really capital and hub cities. It's very interesting to see that that is really where need needs to be targeted. And I think you can see that with 7 sites being selected in the suburbs of Accra. So you can see how that plays out. So I did mention, and I'll just quickly run through these, is just a couple of examples of use cases. These are things that Virtue Foundation's looking at with our partner organizations as ways to change the medical desert in Ghana. And I really use it for illustrative purposes. Our hope and goal with this global health platform is that others can use it for their use cases. But one element we've looked at is partnering with an organization out of Mount Sinai to build an ambulatory surgical center in Ghana, and using the map to determine the optimal and ideal location for it. Currently, district hospitals, that's Dr. Elahi in that photo, with me caring for a patient a few years ago up at Tumu Municipal Hospital, and Dramani, who is the anesthetic nurse there. Dramani does just about everything, including surgery. There's a real lack of access to supplies, equipment, trained people, limited resources, and insufficient surgery per the population. There's like 280 surgeries per 100,000 when there should be 5,000. So there's clearly an issue with access. And this facility that was built in Uganda by the team from Mount Sinai, it was like, well, I have to put it somewhere. And he was just mesmerized by the work that Dr. Elahi was doing, who's also at Mount Sinai, in trying to determine ideal locations. So if we can partner up, they're building this on short dollars, a couple million. It's solar powered. There's a fiber optic cable. You can partner and do surgery in real time, even remotely. They've done thousands of surgeries within this facility. So you can really upskill and scale tremendously through those type of partnerships using this type of actionable data. The other example I wanted to give is the deployment of tricycle ambulances. Our local Ghana Virtue Foundation program director asked us about deploying tricycle ambulances some years ago, and we did. We We put a first ambulance in place that was far more rudimentary than the one that you see in this picture. She's like so many women on these, you see the dirt, that's the roads. They get washed out with the rain. It's impossible to get to the hospital sometimes other than by walking or maybe on someone's bicycle. And you're in end stages of labor. This causes tremendous maternal mortality or infant mortality. So we started to strategically partner with Moving Health out of MIT. And they came and partnered on the ground with a local team of folks who are now what I would call engineers. They brought CAD, they trained them, and they designed jointly, MIT and the local folks on the ground, this newest iteration of the tricycle ambulance. But that's where the map comes into play. We started looking at where are the CHIPs, the small health facilities, where is the local district or municipal hospital, and how do you target the best locations for those tricycle ambulances to provide coverage across the whole region and have tremendous impact on health and particularly maternal mortality. This is actively underway, this initiative, with close to 20 ambulances deployed within that region and scaling. And it's a $3 a day problem that saves 10,000 mothers' lives. This is incredible to be able to use this data to reshape medical deserts by putting care where it needs to be and gaining access for patients where they need to go using data. It's an incredible use of AI and data science. So that brings me to Databricks. And Vandan, very grateful for him. He had worked with us in his prior company at DataRobot, and he was inspired and wanted to keep working, and I'm grateful that he brought in Rob Reed and so many others through Databricks to help us, because we want to scale through Gen AI. We want to continually refresh this data and deepen and create these mini knowledge graphs around each of these healthcare facilities and healthcare NGOs. So, Vandan.
Sure. So as Joan said, and as you probably already heard so far, just that initial step of figuring out where the hospitals are in these low and middle income countries, understanding who from a nonprofit perspective was absolutely game changing. It's allowed the team already to start to advise the governments of Ghana and Mongolia on where they should be placing their next hospital facilities. It saved countless lives. Hugely impactful already, awesome work. But now that we've started to make some impact, now that we've started to develop, we know that actually the situation on the ground is going to continually change. The amount of effort that went in to go and create that first data set was huge. It was something, what was it, 20,000 hours, I think the figure? So that's not a sustainable effort to continue to drive this impact. And actually that first layer of, where are the hospital facilities, we're pretty comfortable about that. But now, because we understand that first layer, we want to go deeper. We want to, bring in more specialized teams, scale the impacts and the work that Joan and her team are doing on the ground as well. So really, this is where we felt that the opportunity was for generative AI. A huge amount of the work that was done in creating that initial foundational data set was looking through raw text information. It was scraping websites. It was trawling through comments and blogs, reading PubMed, all of these sorts of things. And this is a problem that naturally is solved or is naturally applicable to generative AI. So that's what we're starting to look at from a vision perspective here. We start with the internet. That's where all of this is. There's no databases. Ministries of health are just about starting to pull some of this in, and that is going to be a source and something that we want to pull in as well. But most of this is, tweets, it's Facebook pages, it's people's LinkedIn profiles, where you actually get an understanding of the sorts of work that the physicians in these countries are doing, and actually an understanding of what capabilities the facilities have. We already have some really high quality data, and that's a really helpful starting point for us. I'll talk about some of the challenges and some of the things that we need to think about as we start to build this in a moment. But the foundational reference data is treated as really high quality data. It's from a Gen AI perspective, gold dust, because it means that we have a reference point. We've got almost a ground truth data set that we can go and compare against. So many people, as they're starting to embrace their Gen AI journey, they're not thinking about the data science aspect of it. They're not trying to do that whole scale evaluation. So we're in a really fortunate position here where we've got a huge unstructured data set that we want to go and synthesize, but also some really good reference data that we can go and track how our progress is working.
Yeah, that's a great point that you raised, Van Dan, because quite a bit of the foundational reference data we also have validated against some of our partner country data to be able to be sure of its accuracy, so that we understand its accuracy across these 72 countries.
And so what we want to, if we roll back, the final piece on that was, we wanted to then say, okay, well, so how can we then get generative AI, and what's the opportunity? Well, we've got incoming volunteers. We want to scale the overall impact. We've got development opportunities within the countries themselves, and like the sort of medical deserts work, we want to continue with that. And the team are continually publishing the new papers on the overall system level, population level analytics across the countries. And that's really what we want to continue to drive and impact. We've started on this journey. We've only just scratched the surface, but I wanted to give you a little bit of the flavor of some of the stuff that we started to overcome on that journey. We are super early in the journey, and we're super hopeful to get some more volunteers and some more people to help us out. We'll talk about that more later on. But number one challenge here is, as I've just said, this is all over the place. There's no one source of this. There's, no one's writing up these lists. So actually starting to go and do this distributed scraping, we started out with Spark and the distributed platform there. And the vector search piece is also key. Ultimately, you want to go and pull these random chunks of information from different sources. That's a challenge that's naturally suited towards a vector search and being able to embed. We're starting to get a bit more careful about how we want to chunk and prune the data, particularly when we're doing web scraping. A lot of the data is quite low density. So one of the things that I want to think about next is how we can actually raise the information density in the information we're pulling out. The next piece is, we've just mentioned it, we've got this hugely high-value reference data set that we want to compare against. So, we don't want to treat this as work in isolation. We want to build upon what we already have. So really being able to pull the existing reference data into what we're doing is one of the key things that we want to do. And really here we're starting to think about prompt chains. I'm sure lots of you are in the keynote this morning with Ali, like being able to treat that sort of agentic workflow, effectively having those as referrers back to the foundational data set is a key enabler here by combining that with the web sources. And the final one that we're looking at here is covered by the prompts, but it's handling hallucinations. So this is something where we're ultimately wanting to go and feed and fold this into the foundational reference data. This is high quality data. There are physicians coming to actually go and do volunteer work based on this, and there's huge amounts of analytics work going on the basis of this. This is something where hallucinations are not okay, like many industries, but here the impact is really huge. So what are the different approaches that we can use to start to handle some of the hallucinations? We're starting to look at few-shot learning, so starting to put some examples in the prompts that we're using. We're starting to do validation, so some of the early stages of chain of thought reasoning, and we're starting to accelerate the human in the loop. So rather than treating this in isolation, what can we do to prevent a summary to the clinicians, the people on the ground, to say, here's a list of changes that we should make and why, rather than just trying to go and make those changes ourselves. That ultimately means that it's a stage that we could cut out in the future, but it's something that right now we need that extra step in there. So what does this look like then? Overall, it's you start with these distributed sources. We're going to go and scrape. We're going to continuously scrape and pull this information in. We're going to compare that to our existing foundational reference data. So we're going to collect each of these different nuggets across our sources. We're going to aggregate them together and compare to the existing data set. And ultimately, what that gets us to is the suggested updates. So we can see here, and these are actual examples that we've started to pull out now from the foundational data set, and we are actually comparing against that existing foundational reference. Here we can see the sorts of things that we might want to be looking at. So in this case, we've got 2 different facilities where we're looking at whether or not they've got advanced imaging in the facility. We can see that we're giving a confidence score. So, particularly when we've got someone looking at this and reviewing, we can give an indication of how likely this is to actually happen, as well as a text-based reason. So on the left-hand side, we can see that we're confirming that there is still advanced imaging at the Ghana Police Hospital. And on the right-hand side, we can see that the Maternal Child Health Hospital, they've just received a loan from the Ghana Ladies Association, and that's indicated in a blog, actually, that one was, that they might be adding some advanced imaging in there. So typical things that we see in other RAG use cases, we can go back to the original sources of the information to go and verify, and we're cutting out huge amounts of overall effort there. So what next? We're early on this journey. We've only just scratched the surface. How do we scale, and what are the next things that we want to do? And lots of this will be sort of really driven by some of the new advancements. We know this is a hugely changing field, and so I think lots of this will get easier as we go. But the first one is really the web sources used. At the minute, what we started with is the existing web reference data that's based in the existing foundational data set. So we're almost updating what's already there. Now there are more and more different APIs and different routes to go and create, to collect web data and things that are tailored towards Gen AI use. So that's one of the pieces that we want to go and improve on. The next is increasing the depth of the data, starting to look at what data we're actually extracting. A real game changer for the team is getting subspecialty information. I don't know, maybe Nicolas or Joan, if you want to talk a little bit to the impact of that.
Well, for us, the primary thing is to understand exactly the specialty and subspecialty care. For example, in ophthalmology, you want to know, do I need a cataract surgeon? Do I need a glaucoma surgeon? Do I need someone for retinoblastoma, which is cancer surgery in children, or a pediatric ophthalmologist? So the more specific we can be, the more targeted we can be with the right specialist getting to that cohort of patients. So this specialization and nuancing of the data is extremely important to us.
Cool. And the final one on here is the data currency. As we know that, the whole point is that we want to change the state of healthcare in these countries. That means that we want to build this out into a continuous pipeline so that we can continually get these updates and make sure that that high quality data that we already have remains up to date and high quality to be used for those future analytics use cases. And it's not just scaling, it's actually we want to unlock new things for the team. The first one we think is a real game changer. As a physician, if I would come, or any medical professional that wants to go and volunteer, either directly with a Virtue Foundation or use it, that marketplace that Joan described before, we want to be able to give them confidence that the facility that they're going to go to, they actually have the capabilities that they need, and they're going to get most value out of their time going to somewhere far and remote. The second one is the team have done huge amounts of analytics at the specialty level and that sort of higher level, starting to understand more trends and more of these needles within the haystack at the subspecialty level is something that we're hoping to unlock. And the final one is a new area that we've not really looked into so much as already. This is knowledge graphs. So with scaling through Gen AI, it enables us to add a person level. We can start to look at the individual physicians that are working in these different places. We can start to look at, lots of the physicians that work in these places, like Joan herself has worked across many different countries. Actually joining those together and understanding the links that those bring between the facilities on the ground is really important to understand the overall web and the network. So that knowledge graph piece adds into that top one on the conversational piece to actually enable people to drive confidence and understand who's where and what fits together in the overall ecosystem.
Exactly. I think the thing I personally am most excited about is having that AI co-pilot. As a clinician, I can go in and start querying this and querying the sources of that data and asking questions and understanding more about what's happening on the ground. And I think the other exciting piece I can, as Van Dan was talking about, this sort of use cases for a clinician, is how this ties up to the clinical work on the ground, to government policy, to transforming care. I just returned from Mongolia this weekend, where we had a team of 48 physicians and surgeons working on the ground. We've helped build out hepatobiliary cancer surgery there over the last 15 years. It is the largest country in the world. It's the largest hepatobiliary cancer cohort in the world, much more than mainland China. And one would expect that it should be the same, because it's often related to hepatitis and alcohol. So you would expect it to be similar. Our surgeons on the ground decided to take samples of these liver samples, took them to labs in Paris and in New York, and were able to identify that the causative agent was a particle from the burning of coal. So this is a nomadic country. There are people live in gers, but now many of them have congregated. Half of the population lives in the capital, in the 19th largest landmass. Half of the population lives in one city and its surrounding area. So you can imagine coal burning in this area is quite concentrated. And that particle is what's driving this increased rate of hepatobiliary cancer. So we've been able to, through data and through our physicians on the ground, build up the level of cancer service and cancer care, but then also feed that information back to the government, who is mapping also, and we're collaborating, and identifying and changing some of their policy on the ground to address the pollution and the particle from coal burning. So you can see how when you start looking at data in this way, in a geospatial way, and we kind of remove the silos, you now link this all up in development, and I think it unlocks things that we never would have seen before. So I'll hand back to Nicolas, who can showcase kind of a new experience that we're adding. I did want to add, Carto has been also an enormous partner in terms of the geospatial platform, and just to showcase some of what we're doing with the globe.
So we are putting together a new experience to make this data available to global health stakeholders and generally people that are curious about global health. So here you have a 3D globe where you can explore different layers relating to global health. You're looking here at physician density, country level statistics, but we also have the option to go more granular. And here we're looking at specifically the medical deserts and the underserved population outside of the covered areas. This uses H3 indexes to enable zooming in and going granular on the data. And we've been incredibly excited about putting this together. It's still in early stages, but we believe that through this new platform, we can create an experience where we can better connect physicians and, generally speaking, medical professionals with the most relevant medical opportunities in healthcare nonprofits on the ground. So the first facet here is exploring the data, understanding the medical deserts. And the second facet, showcased in this video, is actually being able in one place to search for medical opportunities, so filtering on different preferences and attributes, and then finding results and exploring the landscape. So here we're browsing the globe and we can see actual medical volunteer opportunities. We can see the detail. We can have information about the organization. We have the option to apply from one place, from one platform, consolidated, browse as a list, browse as a globe, like different ways to interact with the same information and create a seamless experience to better connect doctors and medical professionals. And so it's still in early stages, but we'd like to invite you to check out the preview, which is now live at globe.vfmatch.org.
So I hope we've been able to showcase some of what we've done to date and also what we're currently doing with Databricks and where we're headed with leveraging Gen AI into this platform. We have these 72 countries mapped. We've got great pilot programs and partnerships with the governments in Ghana and Mongolia. Very excited by our data partners. Really, this has to be built enterprise grade, and without companies like Carto, DataRobot, and particularly Databricks to support us in this building, I think it's really challenging to put out something that's really at an enterprise grade, which is really what the global health community needs today. We're trying to publish what comes out of this, but most importantly, we're trying to action on what comes out of this. We have so many clinician volunteers. We also have significant data science volunteers, and really welcome anybody who wishes to get on board and assist us with this. You can learn more about Virtue Foundation and Partnering for Impact in Global Health. Big thank you to our partners and really to Rob Reed and Rob Reed and Databricks today. And I really hope, Rob, maybe you might want to say a few words as well and any questions.
It's been phenomenal to see this team come together on a volunteer basis. And the most fascinating thing is that this is changing lives just by using data. It's not magic. It's just, hey, the quote from today was, the future is here, it's just not evenly distributed. Well, let's distribute it evenly. That's the way to go. So phenomenal work, and proud to be working with these folks. So questions?
Well, thank you, everybody.
Thank you.
Thank you.